ಇವರು ಉಮಾರಾಣಿ ಮೇಡಮ್. ಹಾ ಮೇಡಮ್, ಓಕೆ.
ಶಿಕ್ಷಕರು ಇದ್ದಾರೆ ಅನ್ಸುತ್ತೆ. ಇದ್ದಾರೆ
ಯಾ ಯಾ, ಶಿ ಇಸ್ ದೇರ್. ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಳ್ಳಿ ಮೇಡಮ್.
ಓಕೆ ಸರ್.
ಪ್ರಸಾದ್ ಸರ್.
ಸರ್, ಅದೇ ವೆಲ್ಕಮ್ ಮಾಡ್ತೀನಿ.
Yeah, here is Dr. Prasad SN, who is our state IMA Secretary General. He would like to introduce. He wants to welcome everyone. Prasad sir, please.
Thank you, sir. Thank you, Dr. Madhusudan Karigurnath sir, our past president. So, on behalf of Indian Medical Association, Karnataka State Branch, I welcome all of you. Though it is after a long time, we are joining through the private platform. So, it is mandate for all the private practitioners to report the cases of tuberculosis, which includes both primary and extra primary tuberculosis. In this regard, ima-ksb is we have organized a webinar series on tuberculosis and its commitment for the elimination of tuberculosis in India. So here I welcome Dr. Hamsaveni G, NTEP Medical Consultant, WHO. Welcome you, madam, for this program. And also in absentia, Dr. Venkata Chalapatiyam. So he is on presidential tour. He will be joining, madam. Also, I welcome our Dr. Uma Sheshagiri, madam. She is the Senior Vice President of ima-ksb. She has joined here. And also Dr. Suresh Kudwa. He is going to be the president for the next year. He is also here. I welcome you, sir. Then I welcome Dr. Harisha Dilantibettu, Chairman, Academic Subcommittee of ima-ksb, who has joined here. And also Dr. Sanjana Patil Tallur, the Vice Chairman of Women's Doctor Subcommittee. I welcome you. And I welcome all who have joined. Even Dr. Anuradha, madam is there. And Dr. Vijay Kumar is there. So I welcome all of you, all the president secretaries of IMA branches all over Karnataka, who are joined here on the web platform through Zoom, as well as who are participating through YouTube. Thank you. If there are any questions, you can type it in our chat box. And Dr. Amsaveni, madam, I think you will be able to answer those questions. And over to Dr. Uma Sheshagiri, madam, our Senior Vice President, to speak a few words on this topic. Over to Dr. Uma Sheshagiri, madam.
Thank you, Dr. Prasad. And here I am the Vice President, as already introduced by Dr. Prasad. And I want Dr. Madhusudan Karigurnath sir, and also Dr. Kudwa sir, and also Prasad, our Secretary of Karnataka State Branch, and Dr. Harisha, the Chairman of the Academics, and also Dr. Sanjana, who is the Vice Chairman of the Women's Wing, and also Dr. Hamsaveni, who is today's speaker. We want to really, listen to her. I want to say on behalf of Indian Medical Association, Karnataka State Branch, that we are for this program, national programs, eradicating of all communicable diseases like leprosy or malaria. Of course, tuberculosis is today's burning topic, and we need to understand. And I'm very happy to join this webinar series over here, which is going to start. And every Tuesday they are going to conduct. I'm happy about it. And we are also for all the immunization programs, also all national programs. And hats off to our Indian Medical Association. And I thank one and all who are part of this. And thank you, Dr. Hamsaveni. Thank you so much.
Harish. Dr. Harish. Unmute ಮಾಡ್ಕೊಳ್ಳಿ. Unmute yourself, Harish. Yeah.
Good evening. It is pleasure working with the ima-ksb. Respected President, sir, in his absence. And I appreciate the presence of Vice President, Dr. Uma Sheshagiri, madam, the immediate past President, Dr. Madhusudan, sir, the President-elect, Dr. Kudwa, sir, the State Secretary, Dr. Prasad, sir, and today's speaker, Dr. Hamsaveni, madam. And we, as you know, we from academic committee, we are planning to conduct the academic activities. Our committee comprises of the chairman, that's myself, and the members, Dr. Dhanpal, Dr. Prabhakar sir, Dr. Vijay Kumar sir, Dr. Geeta Dupa, Dr. Sanjan Patil Talur, and as usual, as the protocol goes, the president-elect, and the secretary. So this particular committee has got wide ramifications. It includes the academic activity of medical students, the IMA members, the postgraduates, and the research work, and writing articles, and public awareness program. So all this comes under this academic activities. More than that, some of the regulations being framed by the Rajiv Gandhi University as well as the NMC, National Medical Commission. So all this comes under this particular committee. So we thought we should start the program with the VC's note. We thought he should be talking on ATCOM, that is attitude and communication to the medical students. And we are waiting for his appointment, and anytime we might start that program. Now we have an opportunity to have a series of program by Dr. Hamsaveni, a well-known WHO consultant who deals with the tuberculosis and related issues. And we are very happy to Dr. Madhusudan sir for giving that opportunity to conduct the program through academic activity. So I don't want to take much time. Now the people are waiting to hear Dr. Hamsaveni. So now I thank the ima-ksb for giving us an opportunity to host this program. This is a continuous program, and we are going to conduct CME program for postgraduates, undergraduates, and IMA, as well as we are going to conduct IMA quiz program for medical students, postgraduates, and research work oriented issues, and also planning to have public awareness with the NGOs and other organizations. And with this brief introduction, I thank for the opportunity. Thank you, Dr. Madhusudan.
Yeah. Sanjana madam.
Sir. Good evening, everyone. Ellarigu Subha Sanjay. I welcome all respected members to this webinar. Tomorrow, that is 24th March, is a World Tuberculosis Day. The theme of World Tuberculosis Day 2020-21 is "The clock is ticking." It conveys that the world is running out of the time to act on the commitments to end tuberculosis made by the global leader. So today our dynamic speaker, who is connected with the WHO, that is Dr. Hamsaveni, he will be speaking about the tuberculosis, or she will brief us about the tuberculosis. So Madam has finished her community medicine, and she is working in National Tuberculosis Institute, Bangalore, for adult tuberculosis vaccine clinical trial. She is associated with the WHO since 1 year, and supporting technically for Kalburgi Division District. And since last 9 months, she is contributing in Ballari Division, then Chitradurga, Davangere, Haveri, and Koppala. She is also involved in various research activity associated with tuberculosis at different levels. Without taking much time, I would give this platform to Madam to brief us about the tuberculosis in her series of webinar. Thank you, sir. Ma'am, Hamsaveni.
Yes, ma'am.
The platform is for you.
Yes, ma'am. Thank you so much for such a brief introduction, and I'm proud to share my experience along with this web series. Along with the knowledge, we shall have a mutual exchange with the knowledge. That's what I'm looking forward. And I feel this is the most memorable day of the life, where the previous day of the World TB Day, we are starting with the IMA doctors, and with such a high spirit of joining the hands towards the TB elimination. It's my privilege to be a part of all of you towards this TB elimination. Thank you one and all for this valuable stage for me, platform to speak about the tuberculosis. And let's go with the web series. And today, since it's the very first things, I would just want to introduce what are the services that are available in the TB program here. And is my slide visible there?
We can hear you, madam.
Yes, ma'am.
Thank you so much.
We can hear you.
Thank you. So today the topic would be like services offered under the TB program. Now the TB program, when we look at the just brief how it evolved, we can from the National TB Control Program, it went to a revised because of so many lacunae. They revised the program, and it was called as Revised RNTCP, Revised National Tuberculosis Control Program. And now, since last year, December, you can see the logo on the left corner. There is a person who's dancing. There is no gender discrimination here. And the lungs are highlighted here. It means that we are highlighting towards a healthy lung, that is TB-free healthy lung. And to surrounding him, there is a national flag which represents the patriotism, so that we'll have towards the TB Mukta Bharata. Ee kadege namdu elrudu nadge irbeku ano concept nalli we have this logo and surrounded with the NTEP, the program, the renamed with NTEP, National Tuberculosis Elimination, with the campaign mode of TB Harega Desh Jitega in the bottom. This is the very brief introduction for the TB program, and it's my privilege to be a part of this TB program since last 1 year and assisting this division. Almost like 10 districts till now we have touched short experience days, and yet to explore many more in upcoming days. So today, basically the content would be, what is the background, what are the services available in the TB program in terms of diagnosis, patients follow, what are the public health actions we are supposed to take over, and the public-private partnership wherever it's possible, and the innovations where exactly we can stand as a state. The IMA state can take a TB elimination strategies to our next level. So that's what we are looking at with this innovations. And when we look at the studies here, the management in the private sector, there are numerous studies which is actually put up and towards the TB elimination things. But basically the end message, prescribing practices are very good among the private sector doctors. So with this message, the other study also tells that there is an issue. There is an issue regarding the hospital not having the information. The hospital or the private practitioner, when we interact in the, what is the feedback, what we are receiving? There is no enough information what happened to the patients after the diagnosis. Usually the trend will be like once they are diagnosed, most of the majority of the patients will be transferred over to the public sector. Fair enough, the treating doctor is not being informed about it is a big question mark. And here, the lot of flexibility in the program has led all these questions answered till now. So other study tells that regarding the catastrophic expenditure. Today, as we know, today's topic will be the services, whatever is possible in the TB program. But we are looking at what is this catastrophic expenditure, our Indian population, especially in the South India, what is the statistics tells that. We see that the proportion of TB patients with catastrophic expenditure is 31%. Catastrophic expenditure means, it means that 20% of their income will make them so much economically burdened to handle the TB. So that accounts for 30%. So we, being a private practitioners or like hospitals or the clinic, how can we help these patients, TB patients, so that they'll not go for the catastrophic expenditure? This is one strategy or the main background why we are looking at it. And the next one, here we can see there are milestones to achieve the TB elimination. TB elimination is not the 0 per lakh population. It is achieving towards the 44 per lakh population. This is the definition of this elimination strategy. And we have 2020 milestone, 2025 and 2030 and 2035. When it was fixed with MDG, Millennium Developmental Goals, we were not able to reach whatever was the target. Hence, we continued with the SDG, Sustainable Developmental Goals. Why it's being highlighted here? The world target, the global target with the 3 indicators. One is TB death, reduction in the TB death, reduction in the TB incidence, and the catastrophic expenditure of the family, what they are bearing for TB. So these are the 3 indicators which we are looking at. By 2030, that will be reduced by 90% TB death when compared with the baseline will be 2015 data. And the reduction in the TB incidence rate by 80% and catastrophic expenditure to be 0. This is one important thing, the indicator where we are looking at and why we all gathered virtually in this platform. But a way ahead, our country, India, it has taken a call telling that whatever the target is there for 2030, we will achieve this by 2025. This is the a world promise which the India country has taken in front of the global, in front of the 196 countries. It's the only one country which is contributing to 27% of the TB burden. So with this aspect, this is a highly inspirational way where we have to target, we have to focus over the TB. And this is, as ma'am told, it's a very hot topic these days, especially with this COVID pandemic hit. The TB has to be focused to the maximum. So coming to the strategic, let's not go in depth of this. To tell some few words about it, we can see the blue line, which tells about the epidemic curve. The strategy is how we are supposed to tell. Like with your respective district or your clinic, it might be like you can diagnose a few of your TB patients in your clinic. So we have to see that all the respiratory tract infection, the study tells that among 100 new OPD cases, around 60% will be a respiratory tract related. And among them, at least 2 to 4 will be a TB cases. So let's not miss at it. We have to see that we have to reach the unreached by looking at more of presumptive TB cases. So the main basic thing is detect. We have to detect wherever is possible and treat them appropriately as per the drug sensitive pattern. We have to treat them appropriately with the right dose to a right person at the right time. This is most important. And at one point of time, it's our any communicable disease, we have to break its chain. So how are we supposed to do? That's our responsibilities. We have to take up this responsibility as well. And build a sustainable system, which takes a long way towards this TB elimination. So for these things, joining hands overall makes a major role. It's a major strategy which is required at all the stages. So coming to a proper topic of what are the services available in the TB program today. So regarding the diagnosis, we all know like a CBNAT test costs around 2,000 to 2,500 per samples. And what are the services available in the TB program public per se? One is the free microscopy, the NAT, the nucleic acid amplification test. A few words extra regarding this will be, all this day we had a CBNAT, cartridge-based nucleic acid amplification test, which gives us the report. When we submit the sample to the system, it gives us a report by 2 hours. But again, the turnaround time changes with various of reasons like sample collection, transportation, and waiting period. Other high priority cases. So n number of things which matters, reporting may be a couple of days as well. And this was a made in California. This was most exclusive machine. And now we have a TrueNut, which is a made in India. The government is of opinion that every taluka should have this NAT machine. It's a nucleic acid based amplification test. So it's a rapid molecular testing at the TU level. But since we are in a transition period, the district may have at least 1 to 2 TrueNut machines in their respective districts. So why don't we make utilize of these things, which is free of cost? And that doesn't end with the TB patients there. We recommend for the 2 sample test, where 1 sample will be subjected to the NAT. The furthermore, we are looking at the first line and second line LPA. That's a line probe assay, where it looks for the first line anti-TB drugs and the second line anti-TB drugs resistant and sensitive pattern. So here, then it completes the diagnostic cascade, what we call it as UDST, Universal Drug Susceptibility. That doesn't end. Like on a clinical diagnosis, we can see that we can tell by the features that it might be a tuberculosis patient, but we can't predict about the sensitivity pattern. For these things, we have to complete this diagnostic algorithm. And there are people who are facing an issue to reach the public, might be a stigma going towards a private sector, and how exactly, like which lab to go. Bhala face ಮಾಡ್ತಿರೋ ನಾವು ನೋಡಿದೀವಿ. Public lab ಹೋದ್ರೆ ಅಲ್ಲಿ ಸರಿಯಾಗಿ ರಿಸೀವ್ ಮಾಡಂಗಿಲ್ಲ ಅನ್ನೋ ಕಾನ್ಸೆಪ್ಟ್ ಇರಬಹುದು. So there are n number of factors. Even a few experience to share. Few doctors were telling that they hesitate to go to the public lab. So we have a mechanism, that is a mechanism, where even the sample collection, picking from the clinic or hospital, dropping to the nearest diagnostic tool will be incentive will be given for that person based on the per sample or per day. It's up to us how we can actually have an understanding with the district so that we can have that mechanism, a strong mechanism from the private sector, where the samples will be picked up from the clinic or the hospitals, and then it will be dropped to the diagnostic centers. This is one important thing. And the next one is the EPTB sample. As we have a gynecologist, obstetrician, and the surgeon. We have orthopedic. We have a number of the fields where we can have, and we all know this TB affects all the parts of the body except the nail and hair. So in this aspect, we have n number of samples, which is actually might be, that's a presumptive TB cases. So in this direction, we need to look at that. This EPTB samples will be collected in the normal saline. So make sure that the falcon tube, the tube where the samples will be collected, will be kept in the minor OTs or the major OTs whenever you perform operations. So that you will collect those samples in a falcon tube, and that will be IRL lab. That's intermediate referral laboratory. We have 3 in Karnataka, one in KIMS and the other in Raichur, and the third one is in Bangalore, which is recently NABL accredited too. So there is no in the standards of a lab report in this aspect. The only thing is we have to build up that mechanism so that we'll have that reporting system fasten. For that, we need all your cooperation to the maximum. And apart from that, DRTB, these were like DSTB to rule out what a patient is DRTB or DSTB. When coming to the DRTB, yes, we got a report telling that DRTB. It's not like all DRTB patients on an OPD basis, they'll go for a treatment. That regimen can't be planned, right? So basically that needs a pre-treatment evaluation. There are some 13 per se in the programmatic guidelines. So these 13 investigations can be made free of cost for a patient who actually needs that. So this can be escalated. Next, coming to the treatment part. So after the treatment, once he's diagnosed with DSTB or DRTB, whatever, then we have further with the fixed dose combination. Days were there where it was a loose combination where the patient had to take 7 tablets at once, and that goes on with the weight as well. Now we have a fixed dose combination for all the DSTB patients, and DRTB treatment in the form of patient-wise boxes for the convenience of the box, for the convenience of the patient, so that whatever the regimen is planned, that will be written in the box, and it will have its own separate small boxes, division inside the box, so that there'll be no much of confusion what a patient has to take every day. And this will be very patient friendly, and it is available in the public sector as well. And next is, for all these things, we have a weight band available as per the patient's body weight, might be an adult or the pediatric. We have a weight band so that as per the weight of the patient, the number of tablets, FDCs are recommended. Then provision of, this is one important thing which you all can pitch into, where the provision of anti-TB drug supply in the clinic or hospital or pharmacy. The study again tells that majority of the people will actually in the initial stages, they go with the private doctors and the purchasing the anti-tubercular drug in the pharmacy. But after a couple of months, where exactly there is the end with the catastrophic expenditure, like we have seen 30% of them are going for a catastrophic expenditure. They stop, they may be lost to follow-up, their adherence of our treatment is a questionable thing. So we have to answer that. You can be answer for such souls there. So you can have a supply of free anti-TB drugs, and these are macrolides and lupin supply even from the public sector as well. We can make use of these things. And the one wonderful thing we can actually observe in the public sector is linking to a technology. The NICSHI, as we all know, we follow each patient in a system through this NICSHI. We have this NICSHI. Even I personally recommend you all to have this NICSHI app, so that whenever there is a presumptive TB in your OPD or hospital, just enroll the important mandatory things there and just refer to the further testing. And here that can be, the person can be attached to the 99 dots. Fixed dose combination will be given with the sleeves, and the patient just need to give a missed call for that, and that will be captured here. It makes sure that the patient has consumed the tablets by himself. We are it's a technology based monitoring whether the patient is adherent to the treatment or not. It's a wonderful game changer. Again, it can be used as. So coming to the follow-up, as we all know, the follow-up, like every month it has to be followed up clinically, and laboratory wise we have and NCP in the DSTB. So these things can be made where once you notify to the NICSHI, once you notify, the TB patients are notified and they enter the NICSHI, we have a staff in every taluka telling that they can be followed to the patients with your name. Like, for example, we have a PP coordinator, public-private coordinator person at every district. So of the patient telling that we are calling from your clinic or a hospital just to make assure that how are you feeling well or not, any side effects, any areas addressed to be addressed, or anything, any other assistance you want. This is how we are tackling the TB patients as well. The one thing we need is the notification and the follow-up of the patient, and the outcome has to be good. That's the main agenda of all these flexibilities. This can be utilized by every practitioner who is seeing the TB patients in the everyday routine days. Next is the laboratory follow-up. As already told, NIP and CP has to be done to check whether there is an improvement in our TB patients. Per se, there is a sputum conversion or any drug-resistant improvement is there in that patient. So for that, laboratory is a must, laboratory follow-up. So this also can be escalated by notifying. The first important mandatory thing is once to enroll and notify the TB patients. This is the main important thing. Then we have the concept of post-treatment. It means that once the patient completes the treatment, for 2 years, we are looking forward whether he's breaking down into active disease or reactivation of the disease in these 2 years, because the studies tells that 50% of the cases are breaking up in these 2 years after the exposure. The other 50% through once in their lifetime. This is the study tells. Again, we all know it's an evidence-based era. Evidence-based medicine, what we all are practicing. So post-treatment follow-up is a must, mandatory, where for 2 years, the patient will be followed up every 6 months. Next, this plays a major role in terms of any communicable disease, the public health actions, and the COVID made a much more awareness regarding these things. For example, a patient, once he attends the clinic, the counseling in first moment plays a very major role for any diseases like chronic diseases like tuberculosis. The counseling, it includes from the top to bottom, like anything in the, it should be a socio-economic approach for a person. It can be a nutritional background or an economical background linking to a social schemes if possible. And in all way, we have to look at the adherence, loss to follow-up, or any side effects or ADRs, how to address them. So this counseling impact has a major role. I request all my colleagues and friends and seniors in this platform to have some extra this for TB patients, addressing in all the way possible. Then coming to the comorbidities. So comorbidities, here we can see that among HIV persons, there is 16 to 27 times higher lifetime risk to develop TB. And one additional information is among HIV patients, PLHIV patients, if they are breaking down to TB, most of them, 50 to 60%, the data tells that they are the extrapulmonary TB, not the pulmonary TB. So are we looking at it? If so, are we notifying it? Are we following it down? So these are the questions we have to address every day when we go forth with this cohort. Then coming to the diabetes, where exactly the India is the capital of diabetes today. So maximum number of the insulin have been sold in, the majority of the proportion marketing is being in Indian platform. So in this condition, we can see that 2 to 3 times of higher risk of developing TB among uncontrolled diabetic patients. So it's again a double-edged sword. That the patient who are diabetic, they're more likely to develop into active TB disease. And once it is not being controlled properly, it may go for a furthermore the severity form of a TB as well. Next, the smoking and use of tobacco. It's so common. It's so common. Like almost the NFHS 5 data tells that 50 to 60% they're using the tobacco in any form, might be a smoking or any other form. So we have to address this. Counseling, a cessation, and linking them for quit smoking. So these are the things we have to include during the counseling part. Next is a malnutrition. We all know the anemia part and the BMI less than 18.5 are the major issues in India. So here also the TB breakdown chances are very high. And next is during pregnancy. Are we looking at it? Every district or every taluka, we can tell the data tells that at least two pregnant mothers are breaking down to active TB disease. Might be some suppression conditions might accelerating this infection. So we are supposed to look at this direction. Coming to the next, the public health actions, contact tracing. The contact tracing is very much This has been more exaggeratedly stressed during the COVID pandemic. And we all know, again, the TB is a droplet infection. It's spread through a droplet infection. So when a person is diagnosed with a TB, are we addressing their family members? Are we addressing his working place? These are the things which we have to look at it. And yeah, we have hands for your support, your practice, to support your practice in this direction, so that we can actually have a contact tracing activity in the family or even in the working place if he's exposed to more number of patients. And we should also keep in mind, a DRTB patient will be spreading a DRTB itself, not a DSTB. So just imagine one patient is diagnosed with DRTB and we failed at the contact tracing. What will be the burden in 1 year? And one more study tells that in 1 year, a TB patient who is not treated appropriately will be spreading to 10 to 15 persons in a year. So imagine what is the contribution if you're not addressing this contact tracing. In all this direction, the preventive measures. Yes, we go visit to the family, we look at the possible socioeconomic schemes which can be linked, and we look at any comorbid patient who has been exposed so much, or any household condition. What are we doing it to those person? It's a preventive measures. It's again a game changer. Preventive measures for less than 6 years with isoniazid with 10 mg per kg body weight for 6 months. Less than 6 years, 10 mg per kg body weight for 6 months. This have seen that 80 to 90% have reduction with the breaking to the diseases. This is one important criteria again. And with all these things incentive-wise, so the program has a provision to support, to respect the notifying responsibility by the private doctors. Notification, it's DBT, direct benefit transfer, will be like 500, and once the outcome is given by the same doctor, that will be incentivized with the 500 for one patient. So next, coming to the public-private partnership. Yes, how can we pitch in for this TB elimination? You can have your own NAT, so that any like TrueNAT or CBNAT, the cartridges or the chips can be provisioned by the district supply. The DTO can take a MOU or understanding where you will have a NAT in your hospitals, and the cartridges or the chips can be supplied by RN. And next, X-ray at the felt needs areas. This means that there are places where we are missing, like usually the X-rays are used as a screening tool. These days, the diagnostic tool tells that first the person has to be screened, like any presumptive TB patients, pulmonary TB patient, they have to be screened through X-ray. Any abnormality in the X-ray has to be subjected to the NAT. And further, it will go with the UDST, first line LPA and second line LPA. So in a place where there are no X-ray, but there are laboratory which has an X-ray, that can be pitched in towards this effort, telling that for one patient, this will be the cost, and that can be borne by the DTO at their district. So public-private partnership scope is so much open these days. So you can take to any level regarding the patient-centric approach. The one thematic area we can look at it is the way how we are approaching to the TB elimination. It's not from the top to bottom approach. We used to tell whatever the CTD people, Central TB Division tells, the STD cell will carry on the same thing. State TB cell will carry on the same thing, and that will reach the TB patients. No, whatever the patient requires, that can be escalated to higher most, and that can be made as a provision. That is the level what TB program has been more flexible these days. And we still remember telling our seniors telling that like we had always that phobia, because it's a chronic disease. After once it's diagnosed, it will be shifted to public. The follow-up will be lost. Everything, the private practitioner had that phobic. Now the trends have changed. Yes, the private practitioner can take care of patients provided he completes the standards of TB care. There are some 26 standards of TB care. Might be in upcoming days in the web series, we'll complete this 26 standards in one series. So as per the standards of TB care, once he is diagnosed and put on treatment, surely you can continue with providing all the health services to that patient. So that's the flexibility towards TB elimination strategies. Yes, and next, the innovations. Coming to the innovations, what exactly we are looking at it here? Yes, we have so much of provision, a free diagnosis, a free treatment, a free public health actions. What is the our role? Yes, the Karnataka has played a vital role in this direction. I can tell private practitioners in district Koppal that the villages. It means that for TB program, it means that those private practitioners are going to the community, to the villages where exactly might be the TB burden is high or TB is not reported in the last couple of years. So they go, the camp is done with the health department, with the support of the health department, and the doctor goes there and spends his time at least a 1 hour or to 2 hours conducting his OPDs in those camps. And it's a mutual way of output, right? So once the health camp is done by the private practitioner, it's so obvious the community has that health seeking behavior to that person. And once the flow of patient also goes there, he's screening for a presumptive TB. And as well as the ACF like activity, that's case finding activity will be done in that village, telling that the health department people will be going house to house survey. Any presumptive TB persons are found, they'll be like mobilized towards this camp in that village. So that's how the adopting village, and this has become a model and appreciated even at the national level. We're very happy towards it. So it's always a welcome platform to come up with such innovative ideas. And furthermore, the nutritional support might be a few doctors are there where they can't, in their busy schedule, it's very hard for them to provide some quality time for the patients going to their village steps. In that criteria, the nutritional support, few doctors have taken up these as well. All pediatric TB patients are provided with an egg or a glass of milk from their pocket, and that seems like more responsible and the more kind of humanity touch for the TB patients which is required. The TB patients here onwards, it's not just a treatment and completion of a treatment, it's even more beyond it, to approach them psychologically, morally, economically, socially. We have to build such a capability among the TB patients to set an example for the next generation. So in this regard, the nutritional support, as we already told, even this is being practiced in the same district where a glass of milk or a eggs are distributed for DRTB. And there are so many NGOs or so many doctors who have come up sponsoring for the protein powder. And it's all about your decision so that you can help these TB patients. We all know nutrition plays a very vital role to fight this tuberculosis. The next one is the steps. That means that it is a system for TB elimination in private sector. It's the observation what we found in Kerala. I'm just telling the slides is all about setting an example. That's it. We're not asking like the same thing has to be there. The same thing mimicking always welcome. But let's go beyond the things and let's be beyond the whatever the framework or the guidelines what we had all these days, to explore a way where we can help maximum number of TB patients. So here the system for TB elimination in private sector. Here the system was set in what we actually saw, this model was from Kerala, where whatever the notification was there from a hospital was around take it like 10 to 15 notification per month was going on, where approximately the incentive was for one patient it will be 500 for notification. So it was around 5 to 6,000. So the hospital appointed a data entry operator, a person where she sits along with the receptionist with the kiosk there. It's a TB corner, telling that whatever the TB notification is being going on, that will be notified from her to Nikshay. So the data entry operator, the hospital is benefited by more and more TB patients, and she is benefited that the hospital is not paying directly. The patient, because of the notification of this patient, she is being paid there. So out of pocket expenditure from the hospital or the doctor is zero there, but she is being paid and the doctors are benefited and the patients are benefited. This is how the beautiful aspect has came up here, where the private practitioner, they have complete notified, like whatever the enrollment is there, they have the document of it, and all the notified patients they are followed up for the laboratory report to 100%, and all the report as per the report, they're going for a treatment that is being covered, and the success rate is beautifully covered in this scenario. So this is one platform again open for all of us so that we can actually go to a next level. Then conducting OR. Yes, conducting a OR in a private sector plays a very vital role. Let's come up with more and more evidence in our state telling that these are the challenges and these are the how we are supposed to hit those things so that we can actually strike by 2025. We'll go towards the path reaching the 2025 elimination target. So we need more and more research activity and more recommendations so that we can reach up to the 44 per lakh population. That's a huge dream, but we need to touch that path at the earliest possible with these innovations, and any forms of other willingness towards this always welcome or anytime. So with this, we all know tomorrow, that's a March 24th, is observed as a World TB Day. It means that Sir Robert Koch on March 24th, he declared this Mycobacterium tuberculosis. That's when every year we are observing this as March 24th as World TB Day. So here on this day, all this day, it was like we used to observe in between four walls, and it was used to vanish off. But today it's not so. The political commitment and the administration commitment from basic the bottom till the end, till the national level, is very huge. And the Gram Panchayat person is speaking about the tuberculosis today. That's the level of IEC and the community level engagement. And we need to accelerate it much higher. So every 24th, even at the central, every 24th will be observed as a World TB Day. It means that on that day, some activity regarding the TB will be escalated to a higher. Everything will be done kind of. And it's a community-based involvement. So we all know, like in India, the health services are being provided, like 60 to 70% of the health services provided are from the private practitioners. So your involvement and your commitment towards this TB elimination plays a very major role. And let's set a level or a rank very high so that even from the state Karnataka, we can tell that it's a TB free, it's gonna be a TB free air for the next generation. That's the way we are looking at it. And by these sharing my few knowledge about this TB and services, I conclude my words here. Thank you for a patient listening, and please let me know how I can be some help with this discussion. Thank you one and all.
Thank you, madam. John? John?
Yes, sir. Yes,
yeah,
sir.
You are there now. Make everybody to unmute themselves.
Yes, it's there.
Yeah. On behalf of IMA Karnataka State Branch, I thank Dr. Hamsa Veni for that excellent talk on the programs under TB elimination program by India. Definitely, the government is calling for elimination of tuberculosis by 2020. And this is the new strategy by Government of India. It is an ambitious idea to eliminate tuberculosis from India. And definitely, government has doubled its financial resources for elimination for this program. And definitely, CBNAT has come to, UNAT has come to every talukas. And government is introducing, I think, new drugs, bedaquiline and delaminate, that is into the TB elimination program. Definitely, we are encountering the challenge of MDR tuberculosis and XDR, drug resistant and MDR tuberculosis. And in this regard, definitely, as clinicians, as specialists, we have lots and lots of roles to play, responsibilities to play to achieve this goal of the nation. Definitely, we are with the government, we the private practitioners who are providing 60 to 70% of the healthcare services to the patients of India, and we need to take this responsibility. And there is a government order wherein we are supposed to notify the tuberculosis disease to the government, to the authorities, and through the NICSHI. And it is really a very user-friendly media app, the web through which we can notify the diseases. Definitely, we play a major role. And to tell you, I don't know whether it is, what do you call, ಗರ್ವದಿಂದ ಹೇಳ್ಕೋಬೇಕು ಅಥವಾ ನೋವಿಂದ ಹೇಳ್ಕೋಬೇಕು ಗೊತ್ತಿಲ್ಲ. ಬಳ್ಳಾರಿ ಕರ್ನಾಟಕದಲ್ಲಿ 3ನೇ ಸ್ಥಾನದಲ್ಲಿದೆ. ಕ್ಷಯರೋಗಿಗಳನ್ನ ನೋಟಿಫೈ ಮಾಡೋದ್ರಲ್ಲಿ ಹೆಮ್ಮೆಯಿಂದ ಹೇಳ್ಕೋಬೇಕಂತ ಹೇಳಿದ್ರೆ we have totally practically involved to diagnose the diseases. We are picking up the cases. That much ground that we are working. The other way, to tell you the other side of it is, so many tuberculosis cases are there in our taluka, district. That shows that we are actively involved in diagnosis, treatment, and definitely we will achieve the goal. Thank you, madam. Thank you on behalf of IMA Karnataka State Branch, and I request the audience to ask questions in this on this topic, because we have a series of programs on every Tuesday 8:30 p.m. Definitely, most of us are specialists on this platform now. We encounter so much of practical problems in diagnosing not the pulmonary tuberculosis, the extrapulmonary tuberculosis. How to refer, when to refer, what are the things to go about. All those things will be highlighted by Dr. Hamsaveni Madam in the coming series. And I request the members to ask questions regarding today's topic. Really, government is come to the doorsteps of the private practitioners to help the tuberculosis patients. So much of flexibility is there in the programs, and definitely she has highlighted us. And I request the audience to ask questions to her.
Dr. Madhusudan, I would like to speak.
Yeah, madam. Madam.
Yes. First of all, I thank IMA-ksb team for organizing such a wonderful seminar. It's going to be a series of seminars. Certainly, it is the burning issue for all of us. So, Dr. Hamsaveni, I have a suggestion and request. I would like you to put up a page on IMA website, giving us the contact details of the consultants whom we can contact as and when we deal with a query TB patient or whether we are treating. Certainly, the way the tuberculosis is being managed in coordination with private practitioners has been very good, and the medicines are given to our clinics to deliver them to our patients. So my suggestion, Dr. Madhusudan, is we can have a page on our website so that we can contact the consultants, because the practical issue is all private doctors are busy. They themselves take a decision. We are not able to coordinate adequately with the staff. So, Dr. Hamsa, I would like you to throw light on this.
Sure, ma'am. It's my.
Madam.
So can I?
Yes.
Yeah, madam.
Sure, ma'am. That was a very much excellent thing where I can tell it's a pure involvement what I can see through this in this session. So here I would like to reiterate the telling that every district will have a DTO. So district TB officer is the person who can be approached at the district level at one thing. And the second thing is coming to a WHO consultant, we are 7 in number presently in Karnataka. So we have for every 5 districts, one consultant, myself, Dr. Hamsaveni for Ballari division. So anything like Haveri, Koppal, Chitradurga, Davangere, and Ballari, you can call me directly. We'll share the number in recent. And the 5 at the Gulbarga division, Bidar, Yadgiri, Bijapur, Raichur, and Gulbarga. The Dr. Satish Ghatge will be there. He's a WHO consultant for TB there. And for Hubli division, it's Dr. Swati S. Aital. So she'll have Uttar Kannada, Hubli, Bagalkot. So the distribution of these districts will be communicated, because everything I'm not able to pick up the district. We'll surely communicate through Madhusudan sir, so that who all the consultants, 7, and Dr. Devigan in Bangalore division, and Dr. Spurti in Mysore, and Dr. Nishchit in Bangalore, and we have our headquarter consultant, Dr. Shazia Anjum at Bangalore. Surely we'll communicate with these details with our contact number and even mail as well. So you can contact or just a message will be there, ma'am.
Dr. Hamsaveni, can I take the liberty of sharing your number with all our doctors in the different WhatsApp? Is the district tuberculosis officer attached to Bellary district, and she will certainly connect the respective doctors to the respective district tuberculosis officers. Yes. Can I share your number with them?
Sure, ma'am.
Okay. That is to propagate that we are going to participate in tuberculosis eradication by 2025.
Yeah, madam. I want to. Can I have a point?
Yes.
ಯಾ ಪ್ರತಿ ಜಿಲ್ಲೆಯಲ್ಲೂ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಟ್ಯೂಬರ್ಕ್ಯುಲೋಸಿಸ್ ಆಫೀಸರ್ ಅಂತೇಳಿ ಎಕ್ಸ್ಕ್ಲೂಸಿವ್ ಆಗಿ ಟಿಬಿಗಳನ್ನ ಟಿಬಿ ಪ್ರೋಗ್ರಾಮ್ಗಳನ್ನ ಇಂಪ್ಲಿಮೆಂಟ್ ಮಾಡೋದಕ್ಕೆ ತುಂಬಾ ಆಕ್ಟಿವ್ ಇದ್ದಾರೆ ಮೇಡಮ್. ವಿ ನೀಡ್ ಟು ಹ್ಯಾವ್ ಅನ್ ಐ ಟು ಲುಕ್ ಅಟ್ ದೆಮ್ ಅಂಡ್ ಟಾಕ್ ಟು ದೆಮ್. They are really dedicated medical officers are there, exclusive for elimination of tuberculosis. We have Dr. Indrani in Ballari. So likewise, Dr. Nizamuddin was also there, and one DTO from Koppal is, as a young fellow, is so much dedicated towards elimination of tuberculosis. He is the talk of the district now. Am I right, madam? I'm saying, madam. It is one of the role model in Karnataka for elimination of tuberculosis, especially Koppal. Their details are available on the government health and family welfare department notification. Sigutta, easy sigutta.
Thank you.
Yeah. Anybody?
Madam, I have a question. Madam, the statistics shows that the number of cases of tuberculosis in 2020 has come down. Could you explain on this?
Sir, can you repeat, please?
The statistics shows that the number of cases of tuberculosis have come down in 2020. Could you explain on this?
Yes, sir. So this was one thing which we are looking, telling that COVID pandemic might be has reduced the TB per se by using this mask or social distancing, all those things. But we today we can tell that solidly we can tell that it's an under notified TB patients. So many TB patients have not reached the health system at all. They have not reached that. Those person who is coughing is retained at their home. They're not been reached. So that's with the theme, we have to reach the unreached person. One thing. And today we can tell that only 60% of the TB patients are notified. 40% we have missed already. Like whatever the target, like when compared with our previous year, we have missed 40% of the TB cases. And any infection, communicable infection, such a drastic drop down is not expected. The COVID pandemic has hit to a maximum level, telling that we are under notifying, and the study tells that for 3 months, if the notification has dropped down by 30 or 50%, the mortality rate will increase by 12%. It's not about the 3 months, the whole year we have missed so many cases. So we can think about what would be the mortality rate in upcoming days. It's a very high time for us to act immediately, sir.
So we can expect a sudden surge in 2021 because of the spread.
Definitely, sir, definitely. And to tell about this, to comment something about this mask or the social distancing, what the transmission has broken down or something like that, we need some more time. Because as we all know, to comment something about the transmission, we need to know about the pediatric trend. What is the pediatric TB trend? And now we can't comment anything about it. We need another couple of years telling that if the pediatric TB patients are also reduced and the adult TB cases are also reduced, definitely might be COVID pandemic has helped us. But it's not so, never so, sir.
Thanks for the excellent presentation.
Hello, ma'am.
Sanjana madam.
Sir, hello.
Yeah, we can hear you, please.
Dr. Hamsavani, please throw some light on pelvic tuberculosis in your next slides.
Sorry, ma'am?
Pelvic tuberculosis.
Sure, sure, ma'am, sure. We'll have the discussion.
It
About
is a topic on the cards, madam. Extrapulmonary cards.
Extrapulmonary tuberculosis. Sir, basically, stress coating, infertility. That is the cause for infertility, main cause for infertility nowadays. So let Madam stress on that particular subject on her next slide.
Next presentation.
Hello, ma'am.
Madam, there is a session on extrapulmonary tuberculosis, how to diagnose, how to treat. There is a separate session on that. This is a series. Today, we have restricted only to the programs under TB, this thing, services offered. Definitely next, in a Muro series, Gadali, Vella Bertha, madam. Treatment part is also there, extrapulmonary tuberculosis is also there. And she has got a very in-depth knowledge on extrapulmonary cards. She will deal with that.
Okay, sir. Thank you.
Yeah. Sir, Prasad, sir? Prasad? Yeah. Okay.
It's okay, sir. Questions?
Yeah. Shall we go? Shall we end the session?
Yeah.
Yes, sir.
Can I ask a question?
Yeah, please.
Hello.
Please, sir. Subramaniam.
Yeah. Good evening, sir. I'm Dr. Subramaniam, a family physician.
Yes, sir.
And Madam, thanks for the wonderful presentation and making us know about the wonderful system. I am familiar with the system right from RNTC, NTP, RNTCP, everything. We have wonderful system and we have wonderful medicine. Still, we are too far from control and reaching our goal. Probably there is a missing link, that is private public mix. So we have to close down this gap between private and public. For example, there is a lot of changes in the guidelines of treatment, and periodically there is change. I am sure majority of the practitioners are not getting this information. Even the majority of not only practitioners, even the consultants are following the old guidelines, old treatment, and they are not following a common protocol. This may be one of the reasons we are not able to meet the challenge. So we are not getting regular updates. So we should high time to bring every doctor into one platform, into the system, NTCP system. Make a list of all the doctors. Now we have media, mobile numbers are there, IMA list is there. Periodically communicate with them either by email or by mobile, by WhatsApp or whatever way about the new developments and new information, so that keep them updated and informed. Tell them we are with you. Any assistance you want, we are available. Please come. So this is a fundamental requirement to close the gap between private and public mix and update the doctors to follow the new updated guidelines. This is my view.
Yeah, yes, Dr. Subramania, I fully agree with you. That was what I was trying to tell. And Dr. Subramania is popular, at least I have named him as authority on tuberculosis.
No, madam.
So he's a vocabulary or dictionary.
I'm trying to learn about tuberculosis. I'm a student forever.
Yeah. So Dr. Hamsavani, a sincere request. What Dr. Subramania said, I fully agree. We all need to be under a single platform. Kindly look into this. One suggestion is through IMA website. Thank you.
Noted, ma'am. We'll just work out how these things can be in a channelized way. We'll work upon that, ma'am.
Yeah. Madam, ಇದು ಎಲ್ಲದರಲ್ಲೂ ಪ್ರೈವೇಟ್ ಅವರು ನಾವು ಮುಂದೆ ಬಂದ್ಬಿಟ್ಟು ಸರ್ಕಾರ ಜೊತೆ ಕೈ ಜೋಡಿಸ್ಬೇಕು. ನಾವು 4 ಗೋಡೆಗಳ ಒಳಗಡೆಯಿಂದ ಹೊರಗೆ ಬರ್ಬೇಕು. ನಾವು ಫಸ್ಟ್ ನಾವು ಅದರಿಂದ ಹೊರಗೆ ಬಂದ್ಬಿಟ್ಟು ಸರ್ಕಾರ ಸಾಕಷ್ಟು ತನ್ನ ಯೋಜನೆಗಳಿಗೆ ಬಾಗಿಲು ತೆಗೆದಿದೆ. ಸಾಕಷ್ಟು ನಮ್ಗೆ ಎಷ್ಟೊಂದು ಫ್ಲೆಕ್ಸಿಬಿಲಿಟಿ ಇದೆ ಅಂತ ಹೇಳಿದ್ರೆ ಈವನ್ ATTಗಳನ್ನು ನಮ್ಮ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಇಟ್ಕೊಂಡು ನಾವೇ ಕೊಟ್ಟಂಗೆ ಕೊಡೋದಕ್ಕೆ ಅಂತ ಹೇಳಿ ಪ್ಲಾನ್ ಮಾಡಿದೆ. ಬಟ್ ನಾವು ಸಹಕಾರ ಕೊಡ್ತಾ ಇಲ್ಲ ಅದಕ್ಕೆ. ಇದು ಎಲ್ಲರೂ ಒಪ್ಕೊಳ್ಳಬೇಕಾಗಿರ್ತಕ್ಕಂಥದ್ದು. ಪ್ರೈವೇಟ್ ಡಾಕ್ಟರ್ಸ್ಗಳು ವಿ ಹ್ಯಾವ್ ಟು ಗೋ ನಿಯರ್ ಟು ದಿ ಗವರ್ನಮೆಂಟ್, ಎಸ್ಪೆಷಲಿ ಫಾರ್ ಎಲಿಮಿನೇಷನ್ ಟ್ಯೂಬರ್ಕ್ಯುಲೋಸಿಸ್, ಅಂಡ್ ವಿ ಹ್ಯಾವ್ ಟು ಶೋ ಅವರ್ ಕಮಿಟ್ಮೆಂಟ್ ಅಂಡ್ ಪಾರ್ಟಿಸಿಪೇಷನ್. ಆ ನಿಟ್ಟಲ್ಲಿ ವಿ ಹ್ಯಾವ್ ಆರ್ಗನೈಸ್ಡ್ ದಿಸ್ ವೆಬಿನಾರ್ ಸೀರೀಸ್. ಡೆಫಿನೆಟ್ಲಿ ಇಟ್ ಗೋಸ್ ಅ ಲಾಂಗ್ ವೇ ಅಂಡ್ ದಿಸ್ ಆರ್ ಬಿನ್ ಈಗ ಸ್ಟ್ರೀಮ್ಲೈನ್ ಮಾಡಿದೀವಿ. ಇದನ್ನ ನಾವೇನು ಈಗ ಮಾತಾಡಿದ್ದೆಲ್ಲವನ್ನ ವೆಬ್ಸೈಟ್ ಅಲ್ಲಿ ಸಿಗ್ತದೆ, ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ ಡೈರೆಕ್ಟ್ ಲಿಂಕ್ ಆಗಿದೆ. And this will be there ever in the YouTube ima-ksb. Anybody can see these things in the coming days. I think we will end the show, madam.
Yeah. Dr. Hamsa, can you share your mobile number?
Yes, ma'am. I'll just drop in the chat box, ma'am.
Yes.
Please. Thank you so much, sir.
Yeah. Thank you very much on behalf of ima-ksb.
Thank you.
Thank all the participants and also the academic cell chairman Dr. Harish Adalantapettu and Dr. Sanjana Tallur, the vice chairman of Women Doctors Wing, and also I can see Dr. Savita Ramesh for the first time. This is the first time I am able to recognize her. Thank you, madam. Thanks on and on. And on behalf of ima-ksb, thank Dr. Hamsavedi, and we look forward for the next series, madam. Thank you very much.
Thank you so much, sir.
Thank you.
Thank you, Uma Sheshagiri, madam.
Thanks for the opportunity.
Thank you, sir.
Thank you. Bye, everyone.
Thank you, sir.
I'll end the session.